As Dr. Ramakrishnan said, that we plan to consider a very clinically relevant subject, ECT, electroconvulsive therapy. Given that I began my thesis during my MD days with ECT, I thought towards the end of my professional formal employment, I'll use this opportunity to speak about ECT. So, just for some of those who may be students who are logging into this program, ECT was a development that happened in 30s with the observation that seizures reduced psychotic symptoms in people who got spontaneous seizures, and those who had psychotic illnesses rarely got seizures. Although none of these observations, at least the second observation, is not very authenticated. But the fact remains a seizure brings down the psychiatric symptoms, and of course that led to use of seizure induction. Initially they used pentylene tetrazole, camphor, and then they found that unpredictable onset of seizures, so they wanted to have a very predictable controlled seizure induction mechanism, and electricity was the best option. And in 1938, Serletti, whom you are seeing on the picture, and his student Vinny in Rome in the month of April started the first ECT. There's an interesting history about this ECT, although I'm not going into that for the sake of brevity. ECT became, much before the ECT, the convulsive therapies of von Meduna in Hungary and Budapest is something that we need to remember. But what happens today is a more refined version of seizure induction using electricity. Please take it on record that this is one of the longest surviving biological treatments in psychiatry. And initially, when it was introduced in 38, it worked. It worked wonders because there was no other medicine available. And yet, since it was an externally induced treatment, people wanted to examine its efficacy, safety, and so on and so forth, with whatever knowledge of research methods that people had those days, and it was done, and it proved to work in diagnosis of depression and in schizophrenia. And they continued to use it, but in 50s onwards, when the medicines in psychopharmacological drugs came, people also started applying their mind to ECT. Many other inventions happened: anesthesia, muscle relaxation, and more refined form of stimulus to the brain, across the cranium, and electrode placements changed, and the frequency of ECT sessions also, the people did research, and all these things people have already written papers, reviews are available. The fact remains the modified ECT is just not just one ECT. You can have many other variations in that. It can be unilateral, bilateral, bifrontal. A few more others have also come these days. Electricity could be sine wave, pulse wave, although the sine wave has been abolished in most countries, and including in our country, in most places, people don't use sine wave. In the pulse wave machine, you have pulse width, and a host of those things can change. And then ECT need not necessarily be just every day or every alternate day. You can play with alternate days, once in 2 weeks, twice in a week. Some people use it even once in a week. Maintenance ECT is once a month, and there are so many variations. So ECT has gotten refined into the medical practice. But note, and this because of this application of mind of all psychiatrists on ECT research and clinical practice, despite antipsychotic drugs and antidepressant drugs and anxiety drugs which have come into the market post 50s of the last century, ECT has survived very well and is going strong. Though 2 Nobel Prize winning treatment procedures in psychiatry, the malaria therapy and the psychosurgery, were abandoned, and ECT survives and continues to be used. And so it is important for us that we need to uh, uh, revise and periodically update our knowledge, remind ourselves that what we do in ECT, these things for those who are giving ECTs, you're already aware that ECT is administered to an individual who is prepared by keeping himself on empty stomach, also empties the bladder, comes in, gets the anesthesia drug, thiopentone. Today, some people use propofol and other drugs are also used. Succinylcholine, which is a muscle relaxant, and atropine to make sure that the cardia is protected and also the secretions are reduced. Pulsed DC stimulus of a known charge, usually about 150 to 300 millicoulombs of charge is what is given. It is dosed well above the threshold, particularly if you are giving unilateral ECT. Some people use it 2.5 times threshold, 3 times threshold. And in bilateral ECT also, people request it to be used at 1.5 times the threshold. These variations change across ECT centers, across ECT groups, but nonetheless, some of the general principles remain so well above the threshold. You have to monitor whether the person got ECT seizure or not using a cuff method for motoric convulsions and EEG to ensure that there is a cerebral seizure. And of course, he's ventilated all through the process, and ECT is given twice or thrice a week, depending upon the choice of the clinician and the diagnostic condition. So the ECT procedure, we know that seizure is necessary, but alone is not sufficient. The parameters of seizure are under investigation, and no last word has actually been said. Seizure duration, the EEG spectral power, the fractal dimension of the EEG wave signal, the autonomic responses during ECT, the cardiac rate pressure product changes, a wide range of parameters during a seizure are measured. Prolactin response, cortisol response, and so on and so forth. But we don't have a last answer on this matter. But the fact remains that seizure has to be induced, and seizure without a muscle relaxant would be those grand mal convulsive attack, which seemed very barbaric for some people, and it also caused some musculoskeletal injuries. And so many groups abandoned unmodified ECT and made sure that the modified ECT was prescribed, and even laws were brought in several countries to stop using unmodified ECT and make modified ECT as mandatory. And the latest Mental Health Care Act also mandates that we use the modified ECT under anesthesia. There are people who advocate giving muscle relaxation and then go ahead and ECT so that the convulsions don't happen, and they thought it could be safer. But then it was realized that muscle relaxation without a anesthetic procedure or thiopentone makes the individual feel fearful that he has been going into a paralytic state, makes him very fearful. There are, of course, there are variations that have happened. People say you just give diazepam. Diazepam is a muscle relaxant and also quietens the individual, reduces his anxiety. There are viewpoints saying that after all, diazepam is an anticonvulsant and you want to give convulsions with anticonvulsant, it could be counter-therapeutic. So this issue has not been resolved. There are, of course, some studies which say that muscle relaxant as diazepam or lorazepam can be used for ECT-induced anesthesia, come muscle relaxation, and so-called a variation in modified ECT. Last word again has not been said about it. The rules have brought the new mental health bill then, and now it has become the Mental Health Care Act. We have unmodified ECT abandoned altogether. ECT has remained under some sort of a scanner. Countries after countries are bringing more and more laws. One of the recent ones was that the America, they expected ECT to be examined using the new evidence-based clinical trials and to demonstrate that it works. and only then the ECT machine can be sold. So the ECT machine has to be subjected to clinical trials, and this to get a FDA approval, this is going to be a very challenging task and is not likely to happen from the way I see it. But nonetheless, these are all issues that are coming under discussion. So we have been giving ECTs to depression, mania, catatonia, schizophrenia. We don't give ECTs to people who have raised intracranial tension, who have had a recent cerebrovascular episode. Of course, also a cardiac vascular episode, recent one, which has decompensated his cardiac state, is also a contraindication for ECT. All of these are relative contraindications. If you can manage the patient's medical condition on table properly, ECT could still be given, but nobody really dares doing that in routine clinical situation. There are adverse effects. There are some rare but very serious ones, asystole, but more common ones, subjective and objective memory complaints, memory observations. We, of course, have to do a thorough physical examination, avoid anticonvulsants, and reduce lithium to lower end of the therapeutic range. If we are giving anticonvulsants, also keep the blood levels at the lower end of the therapeutic range to ensure that this person is protected. At the same time, convulsive procedure of the ECT is not interfered with. Other investigations like potassium levels, hemogram are done, and some institutions expect even a liver function test to be done and an X-ray to be done, although this is usually not included in most of the recommendations of ECT practice. So when you're talking of ECT practice recommendations, guidelines to practice ECT have come up from various professional bodies and also the governmental bodies. For example, American Psychiatric Association Task Force started giving the guidelines for ECT practice. The second edition the book has come, and this probably will be updated periodically in all the countries. Example, the American Psychiatric Association Task Force talked about where you can give ECTs as a first line treatment and where you have to wait. Don't give ECT as a second line, as a first line of treatment. Give it as a second line of treatment. More or less, all professional bodies, in principle, agree on this with some finer modifications. But we need to perhaps remind ourselves that the chance of giving ECT as a first line of treatment has been coming down over time. I will be illustrating it few examples a little later. You use it only when the treatment effects in terms of producing benefits are expected to have happened rapidly and more definitively in a condition which is very severe, leading to either self-harm or harm to other persons. Patients also can choose that I want ECT as the first line of treatment. And if the past episodes for which the person has been treated have responded very well to ECT, clinicians and sometimes even patients say, look, last episode of my depression, ECT made wonders, so I will continue ECT. And clinician also may say that not going to subject the individual to a drug trial of, or a psychopharmacological trial before giving the ECT. There are, of course, situations where the ECT related risks are lower than the drug effects, the side effects of the antidepressant drugs or antipsychotic drugs or lithium that we are giving to the individual. He needs those medicines, but the risks are higher. You need to add an anticonvulsant to the individual or lithium to the individual, or maybe you have to give higher doses of the drug, and he may not tolerate because of various physical conditions. So I want to give ECT. This is also an option that is given by most professional bodies. You can, of course, give ECT when the drugs fail, when you are given medicines and is not tolerating, so you have to stop the drug or reduce the dose of the drug, which doses which are not sufficient, then you want to give ECT. And of course, ECT, having started the drugs, you find that the response rates are slow, and you want to give ECT to make the response faster. So all this same issue goes on in various countries, whether it's Australia or Canada or UK. Guidelines have been given all in general approve that ECT is therapeutic, helps in depression, helps in psychosis. Although the guidelines have some variations, the British guidelines make ECT a little more conservative than guidelines given by America or in Australia or even in Canada for that matter. So ECT is safe and should continue to be available as a therapeutic option treatment of mental disorders. This is what the Canadian Psychiatric Association has said. Major mood disorders. They also recommend ECT to be given to non-chronic schizophrenia. Chronic schizophrenia, many people say that it is best avoided because ECT is not going to make a difference in them. In depression, again, it is a treatment of choice when the drugs are not working in this individual, or the individual is suicidal or catatonic feature, or he is not eating well, he has got severe biological dysfunction, which makes his physical condition be compromised. And so, of course, the ECT is chosen. ECT is also, like I said, is chosen when the previous episode of depression had gotten better with ECT. Similar guidelines worded differently are also available in the Australia and in the Canadian guidelines. All the bodies recommend ECT to be used in mania, although they talk about ECT to be given in a severe mania and in a prolonged mania. So ECT has a place in the treatment of acute mania. In schizophrenia, like I said, there are some reservations. They want to give it to ECT. They want to give ECT to non-chronic schizophrenia. Acute schizophrenia is to be given. Non-chronic, chronic schizophrenia, ECT is avoided. Although I don't really concur with this totally, there are some studies which show that even in chronicity, ECT has a place in schizophrenia. I'll come to that with some evidence data later on. Indian guidelines for ECT concur more or less with the other international bodies, a little more liberal than what the other bodies have talked about. ECT is given in depression, in mania, in schizophrenia. The definition of acute and chronic are not so well made in the guidelines of what we make. So let me illustrate a few evidence data for these diagnostic conditions for which we give ECT. For example, when it comes to depression, people have examined ECT and what we call as the sham ECT to make sure that the confounding effects of the anesthetic drugs are also taken into account. And the overall data in this chart, we can make out that ECT is helpful in the treatment of depression compared to a placebo, that is the sham ECT. Of course, one of the studies that was done was also from our country, and ECT has been found to be better than antidepressant drugs. Although in the study, which was the perhaps first double-blind prospective study, we had used the doses of antidepressants a shade lower than what today we use, and we were using imipramine, and today the antidepressant drugs have changed. You get the SSRIs, other wide range of newer antidepressants have come. ECT has not been examined with these classes of drugs, but yet ECT works, and one of the strong antidepressant treatment today that is available is still ECT. ECT compared to drugs, again, the meta-analysis suggests ECT is better than drugs. So ECT has a place in the treatment of depression. There are many other treatments that are given to ECT. In the earlier felicitation talk, people talked about Sudarshana Kriya research that we had done at NIMANS. ECT is better than Sudarshana Kriya, and ECT may be as good as antidepressant drugs. Although in the small sample, we could not really demonstrate that ECT was indeed better than antidepressant drugs. RTMS is another common preoccupation with most of the clinicians today. RTMS has also been compared with ECT. In the acute stages, RTMS effects are not as good as ECT. And that is the reason why people recommend ECT in an acute situation and you want to give a more definitive, faster clinical response. This is the work done by one of our former NIMANS student who is now a consultant in UK. This is the work done and showed that acute effects of ECT are better than RTMS, although in the longer period, the ECT has been stopped. Both groups are continuing to get the same antidepressant drug. The differences are, of course, narrowed down. Bipolar depression responds better than unipolar depression when ECT is given. This is again a meta-analysis which was recently published in the Acta Psychiatrica Scandinavica. The response rates and the speed of response and the numbers of ECDs that people use for inducing improvement are also smaller. So ECD gets a better response and ECT gets a faster response in bipolar depression than in unipolar depression. I'll stop here. There is a small correction that is being done to the screen. Just kindly bear with me until it's corrected. In the meantime, if you all permit me, I will have a cup of milk. In okay. So ECT is better in bipolar depression. As you know, as you can see in the previous slide, as many as 75% of them, whether unipolar or bipolar, got improvement with ECT. In schizophrenia, of course, like I said, acute schizophrenia, chronic schizophrenia, and so on and so forth, we have had a discussion. In a treatment-resistant schizophrenia where clozapine is given, even there, clozapine-resistant schizophrenia subjects, ECT is better. And even some secondary outcomes also favor ECT. Example, ECT-treated patients lose weight than those who did not get ECT. So treatment refractory schizophrenia and where even clozapine has failed, ECT has a place. But should one wait till the end of clozapine effect to give ECT is a discussion that we need to do. So having said that ECT works in depression, in bipolar disorder, I have not shown the ECT effects in mania studies. A very, very exhaustive review of this has been published by Dr. Jagadisha in the Journal of Convulsive Therapy a couple of years back. It has been very well cited, and I would recommend people to look at that article. Although there is sufficient evidence for ECT's efficacy in these diagnostic conditions, and of course, ECT is used in many other diagnostic conditions, starting from OCD in individuals with even epilepsy, the individuals with catatonia of another unexplained origin, and even in conditions where there is a medical condition or even a CNS condition, but a psychiatric disorder is there, ECT has worked. So I'm not going into those big range of isolated indications of ECT, but commoner ones, depression, bipolar disorder, and schizophrenia, ECT works. But yet, if you look at the numbers of people who get ECT per unit of inpatient subjects, there is a wide variation between London and the enhanced data. We found that there is a 10-fold variation in the frequency of use of ECT. This has also been confirmed in many other data and studies. Wide variations in the percentage of ECT usage in inpatients and also in the outpatients has been demonstrated. Countries like UK have been extremely conservative, and countries like Nepal have been a lot more liberal. India comes in between, but the fact remains this variation cannot be merely explained by some biological reasons for ECT working and not working in that given population. I think it is also explainable on the basis of some clinician related practices of recommending and not recommending ECT to given subjects in their inpatient wards. Together, ECT use has started dropping. ECT use has been dropping. Yes, we understand in 1938, 1940s, and even until 50s, ECT might have been used as the only treatment, and then on the antidepressant, the antipsychotic drugs came into clinical use, and so the ECT use would have dropped. I agree. But even more recently, in the last, if you take in the last 3 to 4 decades, ECT is now a little more than 8 decades old. And in the last 4 or 5 decades, if you look at the pattern, there is a consistent, continuous drop in the use of ECT. There could be many explanations why ECT use has dropped, but the fact remains a concern to some of us that whether patients have been denied of an effective treatment option that is available to them. Even in Italy, where ECT was started, as you can see the graph, in the last 20 years, there are many places ECT services have disappeared. Entire south of Italy, there are no ECT centers that are available. So this graph, which was recently published in one of the, it is picture that was recently available in one of the articles, is another issue which I want to bring to the attention of all the listeners. ECT practice has been coming down, which may make us become concerned whether our patients are being denied of a very, very effective treatment and even a safe treatment. I'll come to that safety part little later. Why did people start reducing the ECT practice? There are many issues, attitudes, there means concerns, stigma, and so on and so forth. Interestingly, Dr. Andrade, who again is a stalwart in ECT research and ECT practice, has done a survey which is 25 years old, and many of these observations may be true even today. This was amongst the medical students where adverse attitudes and they also harbored a lot of myths. This list of them are here. The fact remains ECT is stigmatized even among the professional circles, doctors, psychiatrists, anesthesiologists, and so on and so forth. It was a great difficulty to get an anesthesiologist to come and help ECT services, and experience many of you as psychiatrists would have faced. The stigmatization of ECT, both in psychiatric and in non-psychiatric medical professionals, is another reason why people really don't use ECT. But is it more recently, although many of these things have been addressed, anesthesiologists are today helping ECT services in many places, and medical students also are very eager to learn about ECT. These this misinformation has come down, but concern in psychiatric professionals is about the adverse effects of ECT, both cognitive and non-cognitive adverse effects. And this is some area where a lot of research has gone on. Just to tell you as a offshoot of all this presentation which I am making today, even I was preoccupied how we can reduce the adverse effects of ECT, both cognitive and non-cognitive adverse effects. So we thought, I mean, there have been many trials, there have been many drugs people have used, including herbal drugs. Why not we try yoga? It may sound very funny. How could the yoga reduce? And then, in fact, one of the students did a small study. The sample size was small, but yet we found a good difference between those who practiced yoga and those who did not practice yoga in word production capacity of these individuals. If you gave yoga practices while they were getting an ECT sessions. Of course, on the ECT session day, they get the yoga in the afternoon. Other days, they get their convenience. They get yoga sessions every day. In a 2-week observation period, we found that yoga practiced individuals compared to those who did not practice yoga, there was some differences in cognitive function. Although the primary variable did not change, the secondary cognitive variables had shown a significant difference between those who practiced yoga and those who did not practice yoga. So this preoccupation has been there in most people, including me. And since I have been working with the yoga, I thought I will check with yoga. Herbal medicine and a host of other medicines have been tried to see whether the cognitive adverse effects can be brought down. Most research in ECT has been how to reduce the cognitive side effects, and people have done a lot of work. But I just want to reassure those who may want to go back and start using ECTs that worries about adverse effects has been perhaps overemphasized in clinical literature. And this table, which is a more recently published article by a person from Denmark who has been doing a lot of ECT research. This is about a meta-analysis of 84 studies. wherein he found that actually ECT improves cognitive functions. Although in the first 3 days after the ECT, there are substantial cognitive impairment. As many as 72% of the variables tested show a lower performance, and these rebound and come back by 15 days. And after 15 days, if studies have been done, nearly many cognitive functions actually get better. So at the end of 15 days, there are no cognitive deficits, and at the end of maybe 3 months or 2 months or 6 months, some cognition actually has gotten better because the psychiatric illness has gotten better. So these are the list of this article is available on the net, though. I want you to observe those values there where it is minus. That means it is not favoring ECT. There was a dysfunction. Where there is no minus, that means it is plus, and the red ones indicate there is actually a positive and also significant change in the memory or the cognitive tests that they have used. And various cognitive tests in detail are given in the y-axis, those lists. And the same is the case with whether verbal or non-verbal memories. So the fact remains that our concern about ECT related cognitive dysfunction may have been overstated in the past, and so psychiatrists might have had a lot of hesitation in using ECT. So I want you to set aside all the studies which were investigated by the earlier series of meta-analysis were on depression. One of the recent studies done in schizophrenia at NIMHANS, we again found that there was a substantial improvement in cognitive function at follow. A more recent study is in process wherein the investigator is looking into the what we may call as social cognition improvement following ECT. The results are still not analyzed, but we have to wait and watch what the figures will be. But cognitive dysfunction also gets better following, as you can see here, at the end of the ECT course, many have been abnormal. At the end of follow-up, which is 3 months later, nearly all of them have become normal. So the adverse effect concern may be overstated, both in schizophrenia and in depression. Again, mortality. Mortality with ECT is again very low. It could be as much as with a minor surgery or a childbirth. We don't know whether the electrical stimulation, the seizure, the anesthesia, which contributes to the mortality. Interestingly, people have found in follow-up more patients had died if they had not received ECT for their depressive episode, and fewer of them, fewer numbers died if they had received ECT when they had depressed. So there are many observations which support that again the mortality with ECT is again is not a thing that we need to be worried about. And in fact, more recently, people are using ECT in people who are elderly, who also have medical comorbidities. No increase in the numbers of mortality rates have happened. In fact, it has actually come down. There are various monitoring procedures. People have become more skillful in managing anesthesia-related complications, and also making sure that the pre-ECT evaluation is done and patients are protected from all these adverse effects. Mortality rates have actually come down, and they are very small, not more than that would happen to a woman who is delivering a child. So ECT works, and ECT is safe. So we have to use ECT. And if you have to use ECT, I recommend that we adopt the MHCA guidelines and make sure, apart from giving ECT to adult subjects with modification, which is now mandatory, in people who are under 18 years, you have to get the mental health review board. If it has been established in your state or in your district, kindly approach the review board and then go ahead and give ECT to those who may need under 18 years. So the issue of giving modified ECT as mandatory has brought out a lot of concerns. We may not have anesthesiologists to come and give ECT to our patients. We are not been trained to give anesthesia, and it adds to the cost of ECT. Although the Ayushman Bharat insurance scheme covers modified ECT costs, but those who are not covered that have to pay from their pocket. It is going to increase the cost. And the decision for the patient has been taken by another body with an assumption that unmodified ECT is indeed barbaric. So this is some issue that people have concerned. What if I am poor, I can't afford modified ECT? The benefits of ECT I can get even if you give unmodified ECT, I am prepared. But then law forbids that. So this is an issue which has been taken up, and I'm sure the Indian Psychiatric Society, the other branches are also considering examining other alternatives. A few of them I have mentioned here, whether the psychiatrist himself can give ECT, or in lieu of the anesthesiologist, can an internal medicine person support the ECT procedure, or the OT nurse who has been trained sometimes, can he or she give the anesthesia, or there can be an accredited course for psychiatrists or maybe for the nurses who can get trained and for purposes of managing the anesthesia for ECT. These are all the suggestions that I think we need to consider and take it forward for application in routine clinical practice. So I have completed my talk. What I wanted to communicate as a take-home message is, number one, just reminding everyone, I'm sure those of you are using ECT know it is effective, and those who haven't been using ECT, which I know many medical colleges have not been training the students with ECT. Some of them may even send them to big hospitals where ECTs are being given to go and get some exposure. But it is possible to train ourselves and train our students to use ECTs because it is effective. You know it is effective, but I think you have to use it. I also want to remind our listeners and those who are in this meeting that ECT is a safe treatment, and even when the drugs fail, it works. For example, the clozapine failure, one of the most potent antipsychotic medicine, ECT works. Use the ECT. Also, I want to remind all the psychiatric colleagues who are here that for various reasons, ECT use has become conservative. Definitely outside the country, and even in our country, the numbers of people who are getting ECT may be coming down in other centers, if not in immense. Other centers, maybe people are having second thoughts about practicing ECT, and so they are not practicing. There could be many reasons. That is a different issue altogether. So the question which I mentioned earlier, concern is that are our people, patients, are they missing one of the most effective forms of treatment that is available to their disease? Could they actually be given ECTs, which we, for some reason or other, we are avoiding to give ECTs? So a judicious, optimal use of ECT should be encouraged. That is the message that I want to send across. But within the framework of what MHCA guidelines have given, let's practice ECT and get our patients optimally benefited from the treatment that we are using. So let me thank each one of you who are here on a Saturday evening, cutting off your other responsibilities and other commitments to listen to this program. And also, I thank each one of you for felicitating me, and I am deeply touched on this occasion. The slides which I prepared today for this presentation, Dr. Jagadisha largely helped me in preparing these slides, and I also thank him for making me possible to make this presentation to all of you. And any feedbacks, my email is there. My official Niman's email address I ought not to be used in future. Kindly send any queries that you have. Again, thank each one of you on this occasion. Let's pray for the Mata to bless us with all the wisdom and to make us wiser than what we were thanks to this program. Once again, Dhanyavad.
Thank you, Professor. Thank you. Thank you. So now words to express our gratitude and our satisfaction of making it ECT as an option. What I have thought in about ECT is about stigma. stigma is more among doctors than among patients. So initial days in 1993, when we started giving ECT, we have to talk and get the consent. When in hospitals days progressed, they see the other patient improving. They say, if you say, sir, you have to give ECT. Immediately they, yes sir, I saw that patient improving. I am ready. See, that is a therapeutic community that helps us to destigmatize ECT. That one thing I observed, sir.
Thank you, sir. Yeah, you are right that each patient reinforces the other patient in whatever the. I have seen this with ECT in the past, and today I'm seeing this in people who are asking for yoga. Although the doctor might not have referred, they will say, "Oh, that fellow is going to yoga. Why don't you send me to yoga?" So, any other inputs to patients other than medicines or any other therapies that we may be giving as professionals, if something else is useful, I think patients seek that, and I think we need to respect their sentiments and then help them to get the best benefit. And today's lecture, I have demonstrated that ECT could be one that we could keep a more open mind than what we have been showing in the recent years.
We welcome Professor Saha for this meeting.
Thank you, sir. Thank you, Dr. Gangadhar, sir, for excellent presentation. Sir, before that, I must say we are lucky enough to get a human like you as a mentor. Whenever we have any problem, not individually, but also organizationally, we always get a help from you. It is definitely our luck that the people like you always helped us. Whatever IPS is doing till now, especially in this recent times also, you know that COVID-19 guidelines about the telepsychiatry, without your help, without the help of you and your team, we cannot do that. We hope that in the near future also, you will guide us like that. Dr. Gangadhar, I told Dr. B.N. Gangadhar is not only a teacher of Nimhans, he's a teacher of teachers. Always, whatever we saw any good, like he is now, whenever he became the director of the Nimhans, now he became the member and maybe the president of the National Board of. But this is always, we feel that it is we have on this. We are always proud of sir. And thank you again to the South Zone, Dr. Radhakrishnan, the president of the South Zone, Dr. Erath, the vice president, Dr. Suresh Kumar, secretary, and all the members of the South Zone for initiating a great initiation of this CME program. Everyone from the country get benefited by this. And sir, one thing only I ask you regarding the presentation at last. I don't know, it is the MCA who, Mental Health Act, that is that modified ECT is only can be given. But somehow I feel in the country like India, unmodified, I don't know whether how much scientific I am saying, but as if you consider, you also mentioned the cost effectiveness, unmodified is really very much necessary for our country. If it's special in the rural people, for the
I have I have a viewpoint on this. The rules apart, in the interest of the patient, somebody took some decision. In the interest of the patient, somebody else has taken another decision. So the patient himself or herself or the patient's family should also be given an option to take a call on this matter. Look, you're going to get ECT. You are free to travel in a Volvo bus or you are free to travel in a cycle rickshaw. Both will lead you to the same place. Cycle rickshaw, of course, there could be a rain and you can the jumps and you can back and hurt. It's okay, but it'll still take you there. Volvo bus also will take you there. So the person should have the option. This is my personal viewpoint, although I am not speaking as a professor or the director of
I do
NIMHANS.
agree with you, sir. I do
So
agree
there
with
must
you.
be some method of rating ECT centers as A, B, C. So he has the choice to do A. Maybe you will give anesthesia, you give EG monitoring, you give ECG monitoring, you have an anesthesiologist fully available. Maybe B, you may give ECT with anesthesia with a psychiatrist being present, not an anesthesiologist. Maybe you don't do any monitoring. And maybe C, where you give ECT without any modification, but all will get him better. So this choice
But
of enduring, if there are any side effects, etc., should be given to the patient. Of course, with some guided decision making. Look, you have to get modified ECT because you have recently had a fracture, or you cannot get modified ECT because there are some contraindication to the anesthetic drugs. So this guidance we could give, but a decision making with the patient's participation is something that I would welcome to happen at some point of time. After all, the entire MHCA is about individual patients' rights. So
thank
this
you,
is
sir.
somehow we need to probably dialogue with ourselves and also dialogue with the government and see whether we can, instead of black or white, unmodified or modified, we could probably say there could be some centers
We should
subject to,
consider
of
the
course,
gray area also, sir. You're right, sir.
subject to, of course, making everything transparent.
Making it. Number
sir.
one. Number two, there is a good option you have mentioned. Like if the psychiatrist can give the anesthesia, then the cost will be less, much
Yeah,
less.
that is another thing that we have to explore.
That is
and see.
another thing, whether we can able to give that or not.
We have to see.
Legally.
Thank you, sir.
Thank you, sir. Thank you for great presentation.
Thank you, sir.
Dr. Aravind, you got
Yes, sir.
questions from the
Yeah.
delegates?
Before that, I would like to start as a chairman of CME, and there is a mesmerizing talk by Professor Gangadhar sir, and it was going in a continuous flow without any chaotic, and a wonderful presentation. Thank you very much, sir. And before I roll out the other questions from the floor, I, as a chairman, wanted to have one first question. Let me start a question from my side. So you have just given one study, the Danish study, that cognition improved better with ECTs. So can we just revise the indications of ECT for, because now we are talking a lot about the cognition in schizophrenia, cognition in depression, cognition in bipolar disorders. So can we really have a clear-cut indication of cognitive factors in indicating ECT for a patient of a schizophrenia or any psychosis? So this is my question, sir.
No, actually, this improvement in cognition is a secondary phenomenon. Secondary to the disease getting better. It's not a primary phenomenon. So, can we give ECT to people who are cognitively disturbed is an issue which I don't think anybody is examined, nor will anybody examine. Number one. Number two, social cognition, which doesn't really get benefited with any of the conventional treatments that we are giving. Whether social cognition gets better with ECT is a question that one of our colleagues is examining. Until he completes his analysis, I will not know whether we have got some data on that. So, are there situations where I want to give ECT? That is the primary variable that he is looking into. Whether social cognition, does it get better? So, but that results are weighted. So, there could be some situation down the line where we may want to give ECT to situations wherein cognitive improvement is the primary objective. But I don't think it is going to come so early, because world over people are worried that ECT causes dysfunction. The whole purpose of this meta-analysis to demonstrate ECT does not cause. If it does, it causes only in the first 3-4 days of the ECT. It is not a permanent issue. So that's the point that I was saying.
This is a great lesson.
So, and the first question from Dr. Ashok Reddy, sir. So the recommended course of ECT is 6 to 8 per course in practice. We usually stop after 4 ECT as good improvement is noticed by 4 ECT, and cost and hospital visits also reduced. So do you really think that we are depriving patients adequate therapeutic benefits by limiting to 4 ECTs?
No, there is no final word that you have to give 6 ECTs. It is not like the antibiotic course, which they say you take for 1 week, and take for 5 days, take for 2 weeks. There's no such course. ECT is symptomatic as of now. So given that situation, once the symptoms are better, you are free to stop it. There are various clinical ways in which people stop it abruptly, or they want to taper and stop. Again, no final word has been said. The results are not very conclusive.
So the second question is from Dr. B. Rajashekar. What could be the possible mechanism for ECT associated weight loss in clozapine treated patients?
I don't have any answer. I don't know whether there's a good mechanism that I can bring in to explain. Many things could be possible, that whether they had in those group of people they had reduced the clozapine effect, because I won't be able to explain that right now. But the fact, these are the observations that have been made. Again, this is, like I said, it's a secondary outcome that people identified during the analysis. The primary outcome was, did it get those clozapine resistant people better? Yes, it got them better.
So your comment on National Mental Health Program banned ECT in India, is it true or false? Question by Dr. Prem Kumar.
Not National Mental Health Program, sir. It is the Mental Health Care Act, which
He has just mentioned. The question has been mentioned like that.
Act says no unmodified ECT. Give modified ECT. And if you want to give ECT to people younger than 18, go to the review board and take a permission.
And there's a question from Rama Reddy Kari. So is it the fear or the rare is a fear of the rare occurrence of the table death which restricts the practitioners to use the ECT frequently, the media judgment and violence of the relatives in the case of death? Legal issues yes.
Like I said, the mortality, I showed the figures. World over, the mortality is so small, and it is not more than what would happen with a childbirth or with a minor surgery. So occasional rare event could happen, and that rare event could happen to anything for that matter. So nobody stops doing those procedures because of a rare event. I think we need to educate the patients' families, tell them that 1 out of 1 lakh treatments, this is going to happen, and you are not likely to be just one of the 1 lakh.
So what is your comment on the role of neurocognitive enhancers during ECTs and post ECTs?
Yeah, so this is many of these drugs have been used, sir, and like I said, even I used yoga, but I'm not sure whether we can strongly vouch that they're going to benefit. And when you're going to look at the benefit at the end of 3 months or 2 weeks, by then anyway ECT effects have gone. The other studies have shown. So I'm not very sure whether they indeed protect, but people are using as long as they are harmless. It is up to their clinicians to use. No such recommendation has come from any professional body to that effect.
I request delegates, one second. I request delegates to give feedback. Okay, one doctor has given. Yes, tell.
Let him know.
Yeah. So what is the risk of dementia in our psychiatric patients who have been used ECTs in the past? Is there any studies, clear-cut studies?
No studies.
No studies. Okay. So, and some of the questions which I have got has been getting mostly repeated or mostly answered by you, sir. So I think with the last question, one question which I just wanted to ask, like, is ECT a neuroprotective?
That is another issue, that it increases the BDNF levels. Antidepressants also increase the BDNF levels. Yoga treated depressives also have an increase in the BDNF levels. Theoretically, it is possible that it increases dendritic arborization. That's what Dr. Andrade has reported in one of his studies. There is a theoretical possibility that it can be not only neuroprotective and neurotropic, but we don't use it for that purpose. It's not that mentally retarded individuals want to give ECT and so they're going to get brainier than what they were. That is not the objective.
I got one question from Dr. Babu Bala saying, what is the role of maintenance ECT now, and what is the current indications?
Guidelines don't talk about it, sir. No guideline has talked about maintenance ECT, but that is probably hospital to hospital, clinician, they vary across practice of. Even myself, till in my entire career, I remember only 2 patients whom I had to use ECT, because that is the one which makes them remain asymptomatic for a period of 1 month. So why such occasional 2 people got better in my entire ECT practice, I have no answer, but I think it goes by trial and error.
I think these are the questions received from the dispenser. So I just wind up the session, and I'll thank you very much for the nice question and answer session.
Sir, another thing what I observed after attending the ECT course in Nimmans, Dr. Jagdisha demonstrated a bifrontal ECT, which I took up. And I think after bifrontal ECT,
Things are better.
things are better. Acceptance is much better. No confusion.
Okay, excellent. Yeah, bifrontal, bilateral, or unilateral, ultra brief ECT. There are so many variations. There are people have standardized for their clinical work one of the procedures.
Sir, and I thank you, sir, for your questions and answers. And Dr. Aravindi's father is Dr. V.D. Krishnaram from Madurai. He was my teacher.
Wonderful.
So he is taking up the mantle.
Now, given that we have had a formal program here, I thought of sharing some good news, and also I think all of us should partake in congratulating 2 people, Professor Andrade and Professor Jacob Vellore and Professor Andrade of Nimmans, who have been picked up as the top 2% clinicians or in psychiatric field in the world, which is something that we all have to be very proud of. Both beings from South. We are talking of Indian Psychiatric Society South Zone meeting.
Yes,
So
sir.
both the psychiatrists identified in India are from South. So I think let's be proud and give them appreciative clap and also communicate it by way of the president of the Psychiatric Society South Zone, writing them a congratulatory letter, which will be reinforcing and moral boosting effect on the psychiatric community in general.
Before we conclude and come to the vote of thanks, we all stand up, give a standing ovation toward standing this for our professor. Thank you. I request Dr. Suresh Badamat to sum up and give the vote of thanks.
Thank you very much for everyone to being here. And before we go for the vote of thanks, sir, one last question as a student to Professor B.N. Gangadhar, sir, my mentor. This is a COVID times. So if a person has recovered from COVID and he requires ECT post-COVID depression or anything, is there anything to be done? Precautions to be done before putting them to ECT. One of our patient is there, so I thought I wanted to ask you, sir.
As long as his pulmonary functions are okay. A lot of people today post-COVID, while during the COVID, he never went through, let's say, oxygen saturation dysfunction. He recovered without any pulmonary signs to the effect of that nature, which means he is fine. You can go ahead and treat him the other way, whichever way. If a person has a compromised pulmonary functions during COVID, they recommend end of the COVID treatment, he goes through a pulmonary function test. But most of us don't go through that. Even I didn't go through that. But ECT patients, it's a good idea if the person during COVID had pulmonary dysfunction, as demonstrated by one of those lowered SpO2 levels, you make sure that you go through a pulmonary function test. This is my recommendation, although anesthesiologists will be able to confirm whether this is a good idea or not. Of course, they will do the routine anesthesiological investigations, what is required for ECT. But in COVID period, people who had a pulmonary decompensation during COVID, but have recovered now and they need ECT, should they go through a PFT is an issue which I putting it across. I think anesthesiologists also have to respond.
Requirement of pulmonary CT, sir?
Not sure. Functions are important than structure.
Okay, right. Thank you very much, sir. You have been clear cut in your discussion, and whenever we have come with the doubts, you have been clarifying all those things, and we are few of those students had an opportunity to be with you, learn from you, and you have been mentoring us, and today we are wherever we are, it is because of teachers like you, and without you people, I don't think we would have been the best, what we call it as in this field. And according to me, the teachers are the one who make us as a good human beings, and you have been there, sir. And definitely today in India, ECT is there, and ECT has made name as a scientific evidence, and the literature you have given to the world is an amazing one. And today your presentation was so lucid and also very crystal clear without any kind of what we call it as confusion. Thank you very much, sir. And we always wish from the fraternity of psychiatry to have a very good what we call it as second evenings, and hope you will contribute more to the medical fraternity now from the psychiatric fraternity or moved into NMC. Hope you do the more greater things. Wish you all the best and have a good health, sir. Over to the president, sir.
What are thanks by Dr. Sai Krishna?
Good evening to all. First of all, I want to thank Padma Shri Professor B.N. Gangadhar sir for being part of first monthly CME program and delivering his lecture on optimal use of electroconvulsive therapy. Your talk had given a lot of inputs to PGs and practitioners regarding ECT and few research questions also for youngsters like us. I want to thank IPS-South Zone President Dr. Ramakrishnan sir for taking this initiative to start monthly CME programs. It will give forum for juniors to deliver lectures and prepare for the next level. Sir, your vision to encourage juniors will prepare a new generation of active speakers who can continue the legacy laid by seniors. We from IPS-South Zone CME Committee wholeheartedly thank you for this initiative. I want to thank today's CME Chairperson Dr. Ramakrishnan sir and Suresh Badamat sir for being part of this academic activity. I want to thank Dr. Gautam Saha sir for his message, Vice President Dr. Ramani Niraj sir, immediate past President and my mentor Dr. Kishan sir, Secretary IPS-South Zone Dr. Suresh Kumar sir, Treasurer Dr. Gangaram sir, Editor Dr. Shahul Amin sir, Zonal Representative Dr. Vishal Indla sir, and all seniors Dr. IRS Reddy sir, Dr. PK Kiran Kumar sir, Somashekar Vijay sir, Ramanan Iraj sir, Babu Bal Singh sir, and Ashok Reddy sir for honoring and felicitation of Dr. Gangadhar sir. I want to thank all EC members, state branch presidents, secretaries, office bearers for actively spreading the information regarding this initiative. Without your support and coordination, it would not have been possible, sir. I want to thank all seniors, colleagues, PGs who had actively participated in this program. Now, I want to thank my own team, IPS-South Zone CME Committee Chairman, Dr. V.K. Aravind sir, Dr. Lokeshwar Reddy sir, Dr. Dayal Narayan sir, Dr. Rajesh Raman sir, for your guidance and support. From CME Committee, under the leadership of Dr. V.K. Aravind sir, we are planning for year-long academic feast relevant to today's day-to-day clinical practice. I am sorry if I had missed any names. Once again, I want to thank Dr. B.N. Gangadhar sir for accepting to be part of this program and felicitation. Thank you all for your patience and active participation. Good night, Shubhratri. Thank you.
We are ending the meeting.
Thank you, sir.
Thank you. Good night.